Okay. Welcome all. My name is Dr. Mary Owen, and I'm the president of the Association of American Indian Physicians. I'm joined here today by Lakita Malson, who is a fourth year. Lakita, where are you?
Right here. It'll pop me up after I talk.
Okay. We are co-sponsors today of an event that is an attempt to help mitigate the impact of COVID-19 in Indian country. We recognize that there is a lot of vaccine hesitancy, and so we are trying our best to get messaging out on the importance of getting the vaccine. I don't know if people have looked at APM research recently, but it shows that we are the hardest hit of all populations. We are dying at 3.3 times the rate of white folks from COVID-19 virus. So it's so critical that we get this information on the vaccine out. We're joined today by Dr. Jill Foster, who is a pediatric infectious disease specialist with a background in vaccines, who will give us a little short talk, and then we'll have some question and answer. We have several members of ANAMS on the panel with us to help us answer questions, some of the leadership in ANAMS, and we appreciate that. Dr. Malson, would you like to, student Dr. Malson, would you like to say a few words?
Thank you. Someday it'll be doctor, but we'll get there. No, I just wanted to say thanks everyone for joining, especially with such a short amount of time in terms of us getting the word out. Like, we're super happy to see as many people as there are on here. As Dr. Owen said, the whole point of this talk and discussion today is just to ask and answer any questions that you might have about the vaccine, so that way we can then go out to our communities and just be able to share this information with others. So definitely a time that's no question is a dumb question. Like, definitely get your questions answered now, because we are recording this, just so you know, so you can keep your video off if you like, no problem at all. You can type your questions into the chat message as well to get those answered that way. And then the recording will be shared just for, again, to get the word out just across Indian country, coming from ANAMS and AAIP with the support of all of these great people who are here today. I think that's pretty much it. So thank you so much, everyone. And hopefully this is a good discussion.
Excellent. At the end of this, after we answer questions, as many questions as we're able to get to, we will have a short presentation of a video that's already been done by Dr. Arnie Vigno. And then remind you all about the opportunity to join in a task force meeting that will be happening on Tuesday at 7 p.m. And this is the task force where we are trying to figure out how to do the best job of distributing these videos and PSAs that are being made right now. We'll also encourage all of you as student doctors who are on here, and student pharmacists, anybody who's part of our communities, to use your expertise from your field to create the same videos and help us spread them. All right, Dr. Foster, you are on. Miigwech.
All right, I am going to try to share my slides. Don't worry, I don't have too many of them. Let's see. All right. Okay. Now, do you see this? Okay.
Sure. Yep.
And now, do you see in the presentation mode, or is it still in the edit mode?
It's in edit mode.
Okay. So give me just a second. This is not, I'm still getting used to this new form of the Zoom that I'm not used to. Okay, let's try this again. There we go. Now you're seeing it. Okay, good. All right. So I've put together a little bit of a presentation. I'm hesitant to do that on a Sunday afternoon, but I went through I've been doing a lot of sort of Q&A stuff, and there's certain things that keep coming back up. So I mean, so the three questions here are: how are these new vaccines different from the ones we're accustomed to, and how are they different from each other? I think that's really important. What are the side effects of the vaccine? Because that's what everybody wants to know. And then kind of more of a sort of metaphysical, ethical thing. Are we between a rock and a hard place here? So the very first thing I always get asked are, why have vaccines? Why can't we just have natural infections? And you know, I'm probably not getting that question from you guys, but these are the questions you're going to get from your patients. So natural infection is you get the illness and then you get immunity to the illness. And for most things, getting the illness, you actually get much better immunity. Or the downside of that approach is really that you don't recover. And especially with COVID, we're really balanced over into that. Or we have the vaccine, which you get immunity without having the illness. But then you have all the vaccine side effects, which, you know, very reasonably so, people worry about. So a little bit on why these vaccines are different. So there were the old school vaccines, the ones that we've all been getting for years, killed virus or live virus. The antigen is injected into you to trigger the immune response. Now, the mRNA vaccines are totally different, because what happens is you are being given the genetic code to then get your cells to make the antigens. So then your cells kind of get hijacked a little bit, start making this antigen. The antigen gets released into your antigen presenting cells. And then these antigens trigger the same immune response as if you had been given one of those killed vaccines. And then antibodies produced. All right, so these are an entirely brand new, different type of vaccine that we've never had before, and that makes people a little bit nervous, and probably rightly so. So, what are the two COVID vaccines that are out there now? All right, so the old school vaccines, there's a bunch of those that were being developed, but they're being used in Russia and China, and they don't seem to really work that well. So instead we have these mRNA vaccines. They appear to be pretty effective. That graph over there on the left is the red line is people getting COVID. If you don't get the vaccine, the blue line at the bottom is if you get the vaccine. Pretty big difference. The vaccine is 95% effective, and it doesn't seem that there's serious side effects. And on the next slide, I'll go a little bit into what side effects we do know about. So the Pfizer vaccine is kind of the old vaccine. We've had it actually for a whole week now. For anybody 16 and older, it's proved a week ago, it requires, you probably heard a lot about the sort of the shipping and the CO2 and how you need to have it really, really, really frozen. It's like negative 100 degrees Fahrenheit. And then once you take it out of the freezer, it's only good for 5 days. And I know in Indian country, that's going to be a problem in a lot of places. So then the one that just got approved this week is the Moderna vaccine. That's only approved for 18 and up. Less of a deep freeze, doesn't have to be as cold. And once you take it out of that freezer, it's good for 30 days. So most people are planning that in the more rural parts of the country, this is the one that's probably going to be used, because it can be, you know, it can get out to a place. You can put it in your refrigerator and store it for a month. Both are approved in pregnancy and for lactating women. Both, and that other than that, there's really not a lot of differences between the two. They're both mRNA vaccines. So what are the side effects? So the biggest thing I hear is people say, can you get COVID from this? Is this like the chicken pox or the MMR vaccine where you can actually get breakthrough disease? So with this, there's absolutely no possibility of getting COVID-19 from the vaccine. I say to people, it's as likely as you can get a chicken from scrambled eggs. There is no live virus. All there is this messenger RNA. The messenger RNA is not capable of producing a whole virus. It can only produce this one little antigen that's the spike protein. Typical immunization side effects were found in this: pain at the injection site, fever, headache, fatigue. However, they are at a higher rate and they are more severe. So up to 30 to 60% of people can get pain at the injection site. I've seen pictures of it that, you know, there's a big red spot that's like the size of an orange that's on their arms. The fever, headache, fatigue can be so severe that people actually have to take off from work. So one of the big recommendations is, if you're planning this for the clinic that you work in, is that you do not give the vaccine to everybody at the same time, because then you will have everybody call out the next day, and that really is not good. So a lot of places are doing like A through F is one day, G through, Q is the next day, and, and then, that follows, so that you have it staggered a little bit. Anaphylaxis, that's the big thing. And that this is the thing that we're still knowing. I was on a CDC call yesterday. There were 2 cases of anaphylaxis in England because they started giving it sooner than us. Both of those people had turned out that they had had anaphylaxis from other things in the past, and yet they still got the vaccine. The vaccine now is being given in the US. The recommendation is, if you've ever had anaphylaxis from anything that was injected, that you not get the vaccine. Initially, the thought was, if you've ever had anaphylaxis to anything like a bee sting or nuts or something like that, that you not get the vaccine. It appears that this is not insignificant. So a lot of what's being really recommended is that after people get the vaccine, they don't just jump up and leave, but they sit and are observed for 15 to 20 minutes. Give them some donuts, give them some orange juice, something, but have people sit around. The majority of people, if they're going to have a problem with it, come within 15 to 20 minutes. What people are saying is, it's interesting that it's occurring in clusters. So that one person at a site gets anaphylaxis, and then like 3 or 4 more people at that same site get anaphylaxis, and then the next day they don't have anybody from anaphylaxis. So it seems that, maybe a little bit of it's suggestive, or it also could be that the site that has one anaphylaxis watches people a little bit more closely. There have been a lot of people that have said their tongue feels a little itchy, or they complain that their mouth just feels a little bit funny after it. So it could be that there's a lot of people having allergic reactions right afterward. All of this with the Pfizer vaccine. We have no idea whether the same thing is going to occur with the Moderna vaccine. In the vaccine trials, anybody who had ever had anaphylaxis was excluded from the trial. So we don't know. And this is something that is really going to be, something that just evolves over, just keep your ears perked up to hear about what's happening with this. There has been nothing weird like Guillain-Barré. So the swine flu vaccine that came out in 2009, when we had the last sort of mini pandemic, a lot of people developed, well, not a lot of people, but some people developed Guillain-Barré. Unexpected, was never seen in the flu vaccine trials before. So people are worried, like anytime you come out with something new, there's always going to be something unexpected. So we're going to do really close surveillance, and I'll talk about that. And it has a slide on its own about what's going to happen, so that we can try to pick up these unusual rare events that may or may not occur. I think the biggest thing that happens with people, I think almost every one of us knows, and I used to get this all the time when I was doing a lot of vaccine stuff, is people say, I went to the doctor and I got my flu vaccine, and then the next day I had the flu. So that happened one of 2 ways. One is they went to the doctor's office and sat in the waiting room with a lot of sick people and did get the flu. But the other thing that's more likely is that this triggers an immune response. And the biggest thing you get when you get an immune response is your body starts making interferon. And then you start having a little bit of a fever, and you ache all over, and you feel kind of lousy. And then most people are going to interpret that to mean, I am now sick. They don't say, wow, isn't this great? My immune system is working and I'm making this great immune response to this vaccine. Instead, they say, I am now sick. And it's scary. And so a lot of people have that. And you will hear of people who are afraid to get the vaccine because they'll say, hey, my cousin got this vaccine and then he got sick from it. And so it's either the cousin went to a doctor's office and sat next to somebody with COVID or the flu and got sick from that, or it was just that their immune system was working. This is really, really important. And we have, as physicians, we have a role in both parts of this. So there's something called vSafe. So everyone who gets the vaccine is going to be handed a little card or a piece of paper that says, please register for vSafe. So this is all done through the smartphone. There's a little QR code. They scan the QR code. And then what will happen is they'll get a text every day saying, you know, like every day for the first 5 days, I think, and then at like 7 days, 14 days, 21, something like that, that'll say, do you have any symptoms from that vaccine that you got? And then people, if they type in no, nothing else happens. If they type in yes, then it takes them to a website for them to record whatever symptoms they're having. That's one way that we're going to be able to tell. And so it's really important that you encourage people to use this. The second is on us. This is the VAERS system, the Vaccine Adverse Event Reporting System. This is that we are going to be counting on providers out in the field that if you're starting to see something weird, that you report it. So this is everything from you give this vaccine and somebody anaphylaxis, you go to the VAERS, and it's pretty easy. You just go in and you type in the information about the patient. This could be something weird. Like you start, you know, you get a patient who pretty much, if you've had a patient who's been vaccinated, who gets anything that puts them in the hospital, you should go onto VAERS and say, this patient ended up in the hospital or this patient ended up in the ER. It could be something like Bell's palsy, Guillain-Barré. It could be that, you know, that they had an increase in their migraines, for instance. But this is the only way that we're going to know of these sort of rare events, of one in Arizona, one in Maine, one in Florida, that we can be able to start tracking through them. So this is the other part that a lot of people come to. There's sort of three groups of people. There's one group of people who says, I'm not getting this vaccine. There's another group of people that are the early adopters who are like, how soon can I get this vaccine? And then I think the majority of people are doing I'm gonna let somebody else get the vaccine and then I'll decide what I'm gonna do based on, you know, how they do it. So, I mean, I think people are reasonably concerned about how fast this vaccine got developed. And I think, you know, one of the things you always want to do with vaccine hesitancy is listen to what people are saying and address what it is they're saying. So the problem is that a lot of people are dying of COVID, and that more than, if you had told me a year ago that we were going to be in the place that we are right now, I probably wouldn't have believed you. There's no cure for it. The behavioral methods of, you know, masks and social distancing and all of that has not been well adopted. We could have maybe bought some time with that, but we all know about that. Not going to go into that. Much of this vaccine development was already in progress. So these mRNA vaccines were being developed, but there was just sort of no disease to attach them to. So as soon as the genome was identified last January for COVID, the vaccine people immediately said, we're going to plug this into our mRNA vaccine. So the vaccine had been worked on for years. The other part that made it a lot faster is much of the vaccine approval process is ridiculously slow because of paperwork. And people are working on this one and that one. And like, just to show you the lightning speed is that on Thursday, the FDA met. On Friday, they approved it. They sent out the approval letters. And on Saturday, the CDC was already meeting to come up with the exact recommendations for people on how to give it. That normally would have taken 3 months. You know, the government would do it. And then, you know, 5 people would have to review the memo. That happened in 3 days instead of 3 months. So that's where some of this is making it a lot faster. And then the other part of this is we don't know. We don't know, but we can't not vaccinate with people dying, as many people who are dying. So that's why we have this plan for the enhanced surveillance, hoping that we get early warning. And I can, you know, I've been on a lot of these CDC and FDA calls, and, you know, people are really being serious about this. This isn't at all well, we're just going to see what happens. All right. So now's the time for questions. I don't know how many of you are on Twitter. There's this thing on Twitter that I'm enjoying. It's called 2 shots in the arm, where people go on and put their pictures after they get vaccinated. And some of the places are having why I got vaccinated. So this is a place that just brings joy in my life. I've done vaccines for my whole career. And so you know, COVID has just been awful. And so this is seeing all these, it's amazing how much you can see people smile, even though they're smiling through a mask. Their eyes really light up. Ask me questions that you have. For anyone who wants to get in contact with me personally, that my email is right there below, foster0267@umn.edu, and I'm on Twitter at Jill Foster MD. I try to put vaccine stuff on as I see it. So I'll turn it over now. And
Dr. Foster, can you stop sharing your screen so we can start to see the people on here? Please go ahead and enter your questions in the chat, and one of our ANAMS partners will pick up those questions and state them to Dr. Foster. Thanks, Dr. Foster. I appreciate your message as well, that we have to listen to what people's fears are. We're not going to be able to address this unless we're listening to people. We can't just bombard them with what we know is the truth. So thanks. Go ahead, ANAMS folks.
Thank you, Dr. Owen, and thank you so much, Dr. Foster, for walking us through the vaccine approval process and some of the kind of precautionary measures that were taken, especially in this kind of perceived rushed development and approval process. We have a few questions coming into the chat and private messages, and I'm going to start off with the first one here, which is how do we kind of work with our patients who are saying that they're not going to wear masks anymore after receiving the vaccine when it's available to the public?
Okay, now that's a great question. And I have to admit, when I've had my 2 doses of vaccine and, I'm out at, Costco, well, I always remember to bring my mask in on my car. Well, Minnesota, I have to, but, I certainly will worry less. Well, the vaccine is 95% effective. So that's really great, but there's still 5% of people that won't be affected. The other part is that the way, and this everybody has to kind of figure out how to translate this into something that people hear, is that the vaccine is effective at preventing severe disease. We do not know yet whether it's effective if people may have mild and asymptomatic disease. They're doing more studying of that. So it's possible, it's pretty probable that you're not going to end up in the hospital if you get this vaccine. And that's great on an individual basis. But you may get a mild case of COVID and still pass it around. So, I've heard of a lot of people who are like, the first thing I'm going to do after I get this vaccine is go hug my mother. Probably, that'd be better if you wait until your mother gets the vaccine too, or you hug her with your mask on, or, do everything that you can. But this really is, you don't want to be in that 5% that didn't get immunized. And then at this point, after this long of not having COVID, now get COVID.
Certainly. And our next question is from a medical student at University of Minnesota. What is the significance of the difference in the lower limit of age for the Pfizer and Moderna vaccine, 16 versus 18? Or is that simply the ages in which people were recruited?
Exactly. It's that there were more people under 18 recruited in the Pfizer version, and this was even there were a few votes no at the FDA, and it was all because there was an argument of whether to approve it down to 16 or not. There was also, these things are so funny because there were the people that are like the really sciencey people who, are looking at the, what was the end and what was the significance. And then there were the people on the other side is like, my daughter works in food service and she's 16 and I want her to have the vaccine. So it was kind of a compromise that there was going to be one vaccine at least that was for the 16-year-olds, and that trial had more 16-year-olds in it.
Mm-hmm. And is there any possibility that with the Pfizer vaccine and the observed anaphylaxis that could be due to adulterants?
It probably is. This has a minimum, well, adulterants is kind of a tricky word because nobody purposely puts anything into the vaccine that doesn't need to be there. So the thinking now is that propylene glycol is part of it. So you all know propylene glycol as not just something you had to learn about in organic chemistry, but it's also antifreeze. But the same way it works as antifreeze, it also makes the lipid envelope around the nanoparticle a little bit more injectable. So this vaccine, interestingly, doesn't have preservatives in it, though. Most vaccines have preservatives. This one does not. Because it is of this different technology, which is also the reason it's only good for 5 days or 28 days. So they took as many things out of the vaccine as possible. So this is probably one of the least chemical vaccines that's out there.
Thank you. Our next question, are there any patient handouts or PSAs that will be advertised to promote these vaccines? And I guess especially within Native American communities.
I would turf that to Dr. Owen. I mean, there's ones of general use that are on the CDC website. In the slide deck that I give you to post, I will include the links to those because there's some really good resources at the CDC. They, however, are just meant for a general audience.
Thank you, Dr. Foster. There are several being developed now. One of the ones that I'm aware of that are coming out most immediately are from the Seattle Urban Indian Health Research Group. And I'm sorry, I'm forgetting their acronym and their name, but we'll post those as well on the AAIP website and put them on our Facebook pages. Yes, there are specific ones. The next question I think is also aimed at us, unless Dr. Foster, you've done your research on natives being represented in the vaccine trials. My understanding is that the only people that were from the South, the only groups that were in the vaccine trials were from the Southwest, and there were about 154 folks represented in those trials. So a relatively small number. And I think part of that is secondary to the same thing that we're dealing with this vaccine. People have mistrust of researchers and government and health systems for good reason. So thanks for the question. Back to you, ANAMS.
Thank you, Dr. Owen. Our next question from Liz Peterson. What are the recommendations for patients who have recently recovered from COVID-19 regarding receiving the vaccine?
Okay, so that's a great question. So there were people in the trial that turned out to have had COVID, which was unanticipated. Their immunity that they developed from the vaccine was just as good as the people who had not had COVID. So it doesn't seem that having COVID interferes with your ability to have good vaccine immunity. The problem is that COVID has been around such a short period of time. We don't know what is protective. I mean, for measles, we can tell you right down to the nanoliter about how many antibodies you need to protect yourself from measles. We don't know. We know that people that have had COVID, the majority make good antibody. Some of them, the antibody goes away. We think the T cell immunity stays around. What does that mean? We don't know. So it's really hard to build a vaccine to something that we're not even sure what natural disease gives you. We do have good epidemiological evidence that if you have had COVID, it is very unusual to get reinfected with COVID within 90 days. So what we're saying is if you've had COVID within 90 days, it's not that the vaccine won't work in with you, but maybe you should put yourself further back in line because there's other people that need it more. So COVID within 90 days, maybe wait until there's a lot more vaccine around. And then you'll probably also be way out of your 90 days by then. It's also not recommended though, too, one little footnote to that is if you actively have COVID, you probably shouldn't get the vaccine. But nobody's done a study on that.
And following up on kind of vaccine structure and mechanism, Pediatric Red Book suggests that Native Americans do not respond as well to vaccines as other populations. Are you aware of any risk of this happening with mRNA-based vaccines? And I guess with the extremely new technology that's yet to be seen, but if you have any thoughts on that.
I think Dr. Foster, if you can just comment on the whole piece about Pediatric Red Book suggesting that Native Americans don't respond as well to vaccines as well. I mean, that in itself is an issue.
I haven't read the section. I mean, the studies are mostly been done with conjugated vaccines like Hib and pneumococcus and things like that. I mean, you probably know more about that than I do, Dr. Owen. I mean, the problem with this, it becomes this, catch-22 is people rightly are afraid to enroll in clinical trials, but then you don't get the representation in clinical trials that you need to know whether in the subpopulations that you're looking at, whether they work or not. So this is going to be one of those things that we're seeing in phase 4 trials, which phase 4 is we release the vaccine and then we watch to see how people do with it. And again, back to how that VAERS is going to be so important. It's going to be so important that if you've got population I mean, the other thing I would put into theirs is if you have patients that you've immunized and they get COVID, I would put that in as an adverse event, because then that's one of the ways that we're going to know that it doesn't work. And if they start seeing that, from South Dakota, that they're getting, they've gotten 20 reports of people that got COVID, then, that's going to make people wake up a little bit. And CDC is going to send somebody there to look into it more.
Thank you. And this next question from from the chat may be a little bit more on the med school lecture side of things, but some of the news today talked about a new strain or variation of COVID in England that had higher transmission rates, but no change in clinical course. Does this, or do the recently approved vaccines protect against this new strain of COVID, or kind of what? It's kind of leading into more just kind of like antigenic drift and shift, and why, we're being mindful of these emerging strains.
Yeah, we have the science answers, we have no idea. Even on the CDC call yesterday in the chat, people kept asking it over and over, and they just kept ignoring that question. I have read, there's a strain that it's very interesting. There's a strain that has emerged in Europe that appears to be, humans got it, humans transmitted it to mink in Denmark. Who do you know there's mink in Denmark? But apparently there were, because they've now killed all the mink in Denmark. And it was a strain that the spike protein seems to be a little more efficient. Now, interestingly, the vaccine immunity is also to the spike protein. We don't know. That's something that's developing, and I would keep your eyes peeled for that. I suspect that in the end, we're going to end up with yearly COVID vaccines the same way we end up with yearly flu vaccines. But COVID is the SARS virus is very different than the influenza virus. So we'll have to see.
Thank you. Another student from the direct messages is asking, do we know where the interest in mRNA vaccine-based technology comes from, and why we're shifting to a different technology as approved to what we've used historically?
The reason is because when you think of, coronavirus has been around for a long time. Coronavirus is one of the viruses that can give you the common cold. Coronavirus, rhinovirus. And people have been working for decades trying to make a vaccine to coronaviruses and haven't been able to. So the vaccines that are out there already, the live virus that killed the virus, the ones, for MMR and flu, they don't work for coronavirus. So people are already looking at, we're going to need a different type of virus to hit these certain pathogens. People have known for a long time the coronavirus had pandemic potential. Things like Ebola have pandemic potential. A year ago, people were working on mRNA vaccines for Ebola, and still are. So there's certain viruses that are just, it's the same reason we have vaccines for Hep A and Hep B, but we don't have a vaccine for Hep C. There's certain viruses that are just really hard to build immunity to with the vaccine technology that we've had. And so we're lucky, hopefully it turns out that we're lucky that mRNA vaccines have come along for this.
And with the vaccine trials ongoing, can you speak to the type and duration of immunity that participants do develop after receiving the Pfizer Moderna vaccines, and kind of the length of time?
So far, the immunity has been really good and long-lasting through the period of the trials. The trials haven't been going on long enough to see much longer than that. But so far, they have found that in the trials, at least the presence of antibody has been good in the majority of participants through the entire length of the trial. They're not finding a significant number of people in the trials, even far into the trial. The problem is now coming, is that it is not ethical to continue the placebo arm of this. So it's going to be very difficult to compare the vaccine immunity to the people that got placebo. And placebo wasn't even really placebo in this. People got the Menacta vaccine. So because we are now going to vaccinate everybody and there's not going to be a placebo anymore, it's going to be a little tricky to get these answers. But of course, it would be, you can't withhold vaccine from people.
And our next question might send it to both you and Dr. Owen. How do we approach and kind of, address the concerns that our Black, Indigenous, people of color patients have with, a long-rooted, I don't want to say mistrust in science. I think it's much more institutionalized untrustworthiness towards medicine and opting to receive the vaccine. Because I believe research from Pew Research Center shows at one time, a majority of BIPOC individuals did not want to receive the vaccine due to many of the concerns that have been discussed already. So if you have any thoughts on that.
Yeah, I'll start with that. And I live with Dr. Nunez, who's the expert on this, and talking to, and I'll tell you what she says. What she says is, are we going to let what has killed us in the past, kill us in the future? That, if you look at this is not a vaccine that people are saying, let's go try it out first with BIPOC people. If you look at the 2 shots in the arm website, the majority of people on that website that are getting it are white doctors. And so I think you can say that this is not something that is being like, let's try it out first in our indigenous folks. So I think it's that don't use, and I'll be very curious to see what Dr. Owen says, but don't use what's happened in the past to hobble you in the future in this. This is, I think, with the disproportionate number of people dying in Indian country from this, I think it's even more urgent for the vaccine to be given there.
I think that the question asks 2 things. Why is it so important? And then also, I think you're also asking how to do this. So for the why, I don't know if everybody saw at the beginning, I held up this graph, and this is from APM research, and it shows you why Native people are dying at higher rates than any other population in the nation. Just like we did from H1N1, we died at 4 times the rate of other populations for lots of different reasons that we don't need to go into here. And I think that most of you are aware as Native people. We have to convince people how much more we are being impacted by this disease than anybody else. And we've, smallpox almost wiped us out. We can't have the same thing happen again, as Dr. Foster alluded to. But as to the specifics on how to convince our populations, Dr. Foster also alluded to that by saying we have to listen to people.
Yes.
Just like we see our rural people making voting decisions that we don't always agree with, maybe we need to be listening as to why. People are suffering, and we have to listen to why before we can get them to listen to our responses about this. We are all, I think, sometimes take it for granted our expertise, but not everybody gets access to that same expertise. So we have to be patient, ask why, and then answer the questions gently and patiently without getting frustrated. Dr. Vigno is an outstanding communicator, though, with our patients, and I know he's on the line. Anything to add to that, Dr. Vigno, and specifics to address this with patients?
I think everybody's seen some of the Facebook threads that happen in Native country, and people, once one of those things gets started, they're kind of spectacular in how fast they can spread and build fears, and with a lot of myths stated as fact. And, I think Dr. Owen is right, that we need to listen to those, we need to listen to those fears and not just put them down, because that has never worked. And so we need to look at those. We need to address those. The video things that we've done, we looked at doing kind of a standard script, starting with, hello in your native language. And, I'm Dr. Arnie Vigno. I'm, list your tribe, Anishinaabe, and I'm with the Association of American Indian Physicians, or the Association of Native American Medical Students. You should state that, because it gives us a unified front. And, and there is strength in numbers. And I think a lot of people, when they have Native providers, they love that they have Native providers and Native medical students, but they don't know that we're part of a bigger organization, that there's a lot of us out there, and we have Indian country's health at our interest, at our best interest. So, so having a standard script like that, and then you just list 1 or 2 points. The first one we did was the vaccine is given in a series of 2 shots. The the second one is 21 to 28 days later, and then help us end this pandemic, get the vaccine, and then some hashtags following that. But doing big long things is maybe kind of overwhelming. If we did a lot of short videos, and then they just see us again and again, and you cover short points, you cover the things that people are talking about in your communities. You point out that I also write, so there's a thing coming out on Indians.com tomorrow, just talking about the vaccine, and another one, will be coming out talking about the fears of the vaccine and addressing the myths. And that part will be, looking at, people need to look at factual places, getting and pointing that out, that we can't get our news from Facebook and social media platforms, because there's too many myths and too many scare things out there, and scare things work. We know that. So addressing those. So we'll play that video, but the videos themselves, or at least the way we envision that, is that there's a standard opening line, a standard closing line, and then just a short fact in between there, or a short, debunking a myth, or whatever is important for your communities. And again, pointing out that we are part of a bigger organization. And I think Native people are going to respond to us as Native providers. And and for medical students, this is the whole med school thing, and getting into med school and making it through that, when you know that as you were getting into medical school, that other people that were started out with you fell by the wayside. It's a difficult journey. It's a difficult process doing this. No one bet they were going to be part of a pandemic, when they applied for medical school or went into this. And some of our elders point out that if you look back at the 1918 flu pandemic, there's nobody alive from that, but the similarities are there, and the stories are there. We are the new ancestors, and someday people are going to look back at us and wonder how we got through this. And and we're going to have a trail. We're going to be leaving a trail with with the things that we're doing now, and the videos that we put out there, and they'll know that we survived this because we changed ourselves, and we changed our people. And this is a medicine is a good gig, and we do have the ability to really make a difference in people's lives. So we have the video that we'll show here shortly.
Thanks, Dr. Vigno. There's one question here from Melissa Townsend. Thanks, Melissa, for your question. You said you've heard some suspicion because the IHS and our tribal sites in Minnesota, particularly because that's where you're at, got the vaccine early on before other populations. And it is because we are being hit so much harder by this illness. We happen to have a really, our state, Minnesota Department of Health is better, I think, than a lot of state departments of health, and was organized and is doing a nice job. And our IHS has listened and got us the vaccine when we needed it. So it's in response to the fact that we're being impacted so high. Back to you, ANAMS.
Thank you, Dr. Owen, and thank you so much for everyone's insights. We're so fortunate to have many of our AAIP leaders and mentors here on this call and town hall with us. And I think, speaking to Melissa's question about concerns about prioritization and allocation, with the 1918 flu, American Indians had a 4 times higher mortality. For H1N1, 4 times higher mortality. And now with COVID-19, we're seeing a 4 times greater hospitalization rate. So I think it's really on everyone to ensure that Indian country has a voice in this process. A question that we had from Dana Silva is that if patients with COVID shouldn't get or active COVID shouldn't get the vaccine, are we recommending to patients that they should be tested and receive a negative COVID test before being vaccinated?
No, we're not recommending it. And a lot of the recommendation not to get it is that, one, you don't want people with COVID sort of standing in line with the other people, you know, back to my thing of getting flu from being in the waiting room with a lot of sick people. And then, but there's no, in general, you don't want to vaccinate people who are sick. I mean, you don't want to vaccinate people who, and their low-grade fever is one thing, but in general, do not give a vaccine to somebody with a fever over, say, 100.5.
Thank you. And we had one question sneak in from Samuel Williams here. What would you say to patients who might want to wait to get the vaccine until some of the other vaccine candidates receive approval, like AstraZeneca or Novavax?
Those are also both using new technology. I mean, if somebody told me, for instance, that those vaccines had were like a really good version of vaccines that we've been using for years, I might say, you know, wait for it if you can. But I would say wait for it if you can, if you're somebody that lives in a population of people that don't have low mortality, that wear masks all the time, and, you know, are able to socially distance and not go into a workplace. So I think you have to take what's here now. Both of the vaccine trials, especially the AstraZeneca one, had problems in their methodology with them. They were a little bit sloppy in them, and are going to have to go back and do the statistics again. So it's going to be a while for those vaccines. So I say carpe diem in this.
Thank you. And another question that just came into my private messages is kind of thinking of, now that vaccines are now becoming more available, especially on to the middle of next year, how do we address parents' concerns that their children cannot be vaccinated, but it's safe to return to school wherever they may be attending school?
Okay, the children probably can get, I would guess that vaccines for kids are probably going to come out near the end of the year. The same focus now that was earlier this year for getting people into clinical trials is starting for children. And so I think we're going to have data from children pretty soon, so that hopefully children, you know, cross fingers, you know, by the time they'd be going to school in the fall, we might be getting that age limit down a lot lower. A lot of this has to do with, you know, you hear a lot about herd immunity, but a lot of this has to do with how much is out there in the population. So if you can get the amount of disease knocked down in the population, you know, I think of it as, I'm going to walk through a swamp with alligators. And if you've got 100 alligators in the swamp, you're probably going to get bitten. But if you've only got 2 alligators in the swamp, you can probably make it through. So if we can give vaccine to the adults, then we can knock the levels down, then it's just going to make that swamp a lot safer to walk through. And so, and kids don't give it to each other as easily as adults do.
Thank you. And I believe our final question before we transition to the video is the Pfizer vaccine recommended for individuals with bleeding disorders that may be on blood thinners or on blood?
Nobody would ask that. The vaccine is given IM for people with hemophilia and other bleeding disorders. There's been alternative ways of figuring out how to give the vaccine. That has not been figured out yet. I would say have a really good, if you have a bleeding disorder, have a really good conversation with your provider to figure that out. And I think soon guidance will come out of that, and perhaps you can give it subcutaneously, but it may not work as well. Immunocompromised people should take the vaccine. Again, it's not live virus, so somebody who's immunocompromised, the only downside for them is it may not work as well because of their immunocompromise. They may not be able to build the nice immune response, but I don't think there's a downside for people who are immunocompromised, and they're the ones who are most worried about getting COVID.
And then something
I think, Alec, Melissa, I'd like to answer your question outside of this. If possible, you and I can have another chat, okay? Because we're going to try to avoid those ones right now. We're really trying to get the information out for our community members. So go ahead, Alec.
Thank you, Dr. Owen. And we'll have the chat saved and we can get in touch with everyone. Lakita posted something that was emailed to us in advance of the town hall. This individual said, and I quote, "I always get sick after getting a flu shot. Hence I tend to take ibuprofen before getting flu shots and for a week after receiving one. Thus, is it contraindicated or ill-advised to take ibuprofen with the COVID-19 vaccine?"
Do it. I'm a pediatrician and I always told my families to give their kids, I usually use Tylenol, but do it.
All right, thank you. And thank you, Alec, for moderating those questions in such a good way. Right now, let's go ahead and turn over to a sample video that Dr. Vigno has already made and that we will be posting. We have, I think, at least a couple of them done that we will be putting up on our website and our Facebook page. They were done by with the guidance of the AAIP Vaccine Task Force. And that task force will be meeting again Tuesday at 7 p.m. Central, I believe. If I'm wrong, I'll make sure that we post the right time for you all, or send it out to everybody who's on this call today. And if you care to join to learn more about how to make your videos and how to get them distributed, you are absolutely welcome. So we will ask you to contact, I believe, Alexandra, that you volunteered to be the contact if you want to put your name.
No, it was Lakita. I'm going to put it in the chat.
Thank you, Lakita. If you want to join our task force, go ahead and email her and she'll get you hooked up with our Zoom link for that meeting. So right now, Dr. Vigno, Ivy Vigno, can you guys show your video? Are you able to?
Yep, we're gonna show it. I'm gonna share the screen. I want to give a huge shout out to Dr. Missy Begay, who is the chair of the Public Relations Committee for the Association of American Indian Physicians. And she is magic, pure magic. So Arnie and I shot a couple of videos, like 6 videos at his clinic last Tuesday. And I sent them to Missy, who edited them. So all the videos we're encouraging you all to make these videos kind of based off of the one that we're gonna show. And then getting those PSAs, short PSAs, 20, 25 second, however long, to Missy. And then she'll fashion them after this one so that they have the same brand and look and things like that, and shoot them in a landscape or horizontal fashion, if you would. So here we go. I'm going to share the screen. Hopefully this works. Share. And I'm going to go to here. Can people see this?
Yep.
Yeah.
Okay. Okay, let me turn it up a little bit. Oh, it's up.
Who's you? I'm Dr. Arnie Vigno. I'm with the Association of American Indian Physicians. I'm an Anishinaabe and I'm a family practice physician on the Fond du Lac Reservation in Minnesota. The COVID-19 vaccine requires 2 doses, 21 to 28 days apart. The first dose primes the immune system and the second dose gives optimal immunity. Help us end this pandemic. Get the vaccine. Miigwech.
Very cool.
Yeah, okay, so stop share.
So very short little clips about one piece that's really critical to pass on. And we have a list of those that our task force has come up, a list of important points. I don't suppose you guys have that list on you right now, Ivy, that you're able to show. I don't know. If you're not, no worries. I didn't, okay. If you come to our task force meeting on Tuesday evening, you can see the list, and we'll probably try to post it as well so that people are aware ahead of time of what we're looking for on those videos. No, Shelby, those videos are not going to be posted. We have one lead video, and that's mine, that I'll be done with here in the next, well, as soon as Missy does her magic on it. And then we'll start kicking them out one by one, and we will be posting them on AAIP as well as our Facebook, our social media sites, right? And then we'll ask you to help spread those around in your community. The other thing to think about are doing PSAs for your radio station. A lot of our folks still listen to the radio and might not have access to computers. All right, I want to thank everybody for spending the time to learn these messages, answer questions that our patients and our community members are going to have. And then I ask you to take what you learned today to spread it out into our communities, talk to your aunties, your moms, your dads, any community member. Spread the good word about these vaccines and how critical they are to lessening the impact in Indian country of COVID-19. I want to thank Dr. Jill Foster for joining us on her Sunday. Two times she has given this town hall in the interest of helping us in our communities. And I want to thank our ANAMS folks for co-sponsoring, particularly when I know that they are busy with tests and also interviewing many different interviewers. So good luck to all of you on your tests. And again, thanks to everybody who's joined us. Anything else to say, Dr. Foster, in closing?
No, it's been my pleasure to join you on these Sundays, and for everyone entering the match, good luck.
Student Dr. Malson, anything to close with?
Just want to say thank you everyone for showing up, and just again, get the word out to as many of the individuals that you know and share about all of this. And then just a quick thing, Dr. Owen, the task force is at 8 p.m. Central on Tuesday.
Oh,
so just letting everyone know, again, email me if you want to join and I can get you connected. Otherwise, this was awesome. And thank you, Dr. Foster, for being a part of this, as well as AAIP members for also helping to put this on and share all of the information that you have on this. I think this is a really great thing for us as students to be able, and other members of our community to be able to share with others. So thank you so much. This was really great.
Miigwech, and with that, we will close. Thank you, everyone, and happy time off. I hope everybody gets some rest. All right, take care.
Thank you so much, Mary.